Hey everyone, welcome to episode 70 of my podcast, Anatomy and Physiology Bit by Bit. I'm your host, Dr. Steve Sullivan, coming to you from Bucks County, Pennsylvania, just north of Philadelphia, the birthplace of the United States. In case you missed it, I've been teaching A&P in Bucks County Community College since 2002. And if this is your first time listening, let me encourage you to download all the episodes so you have them at your fingertips whenever you want to review any organ system in anatomy and physiology. And if you're an A&P student, you should start with episode 1 and go in order. Today's episode starts our discussion of the reproductive system of biological females. In the last episode, we covered the biological males, but let's face it, men are simple creatures. Women are much more complex, so we're not going to finish this in one episode. Before we switch to biological females, however, I want to answer a listener question about biological males that I didn't cover in the previous episode. Last week, I got an email from Jenna, an aspiring physician assistant in San Antonio, Texas, and she wanted to know if men experience anything similar to the changes of menopause in women. That's a great question, Jenna, and I should have brought this up in episode 69. My apologies for that oversight. And the simple answer to your question is yes, but really, no. I'll explain. Biological women experience menopause, which means they are no longer menstruating and can therefore not have children. We'll discuss that later in this episode. Biological males also experience a decline in sexual function, but they can still produce offspring. In men, the decline is sometimes called andropause or male climacteric. But those terms aren't great because it's not the same as menopause, and it really shouldn't be considered as such. Either way, I'll explain what happens. Beginning after 40 years old and continuing until death, the response the testes have to luteinizing and follicle-stimulating hormones diminishes. This is because the number of interstitial endocrine cells in the testes declines. At the same time, the overall level of testosterone secretion goes down at a rate of about 1% per year or so. As you can imagine from what you know of testosterone, that means a decrease in libido, or sex drive, loss of muscle mass and bone density, which increases the risk of osteoporosis, slower beard growth, and atrophy of the testes, penis, and seminal vesicles. You also see a decline in semen volume, sperm count, and sperm motility. But this doesn't mean infertility. Some men continue to produce offspring well into their 60s and 70s and beyond. In fact, Mick Jagger of the Rolling Stones fathered a child at 73 years old. Actor Robert De Niro became a father again at age 79. And Al Pacino? He had his youngest child at 83 years old. Even though the sperm count is high enough for fertilization, the quality of spermatozoa declines as we get older. The number of new mutations that occur during spermatogenesis increases, and that's why. So we end up seeing an increase in the number of miscarriages, and we also see an increase in conditions like schizophrenia and autism spectrum disorder when the father is in advanced age. The decrease in interstitial endocrine cells also means a decline in the negative feedback mechanism that inhibits FSH and LH. I talked about that in episode 69. So those numbers rise, causing mood and personality changes, depression, and fatigue. And the testosterone decline also contributes to those. When men get into their 60s, we start to see erectile dysfunction, which means they often have a hard time obtaining or sustaining a penile erection. We typically see this in about 20% of men in their 60s, and by the time they get to their 80s, that number rises to about 50%. All right, Jenna in San Antonio, I hope that answers your question. Thank you for listening and for reaching out. And remember, you too can ask me a question. Just email me at minus55media@gmail.com. I'll put a link in the show notes to make it easy for you. Now let's get started on the female reproductive system. As I said a couple of episodes ago, for sake of ease, when I say male and female, I am talking about biological males and females, people who do not fall into the category of intersex. Also, I'm talking about biological sex, not gender. These are two different things. We'll begin with the anatomy of the female external genitalia, also known as the vulva, which consists of several anatomical structures that play vital roles in reproductive and sexual functions. There's a lot of structures of the female and male reproductive anatomy that are related to each other, so let's explore each component in detail. The mons pubis, which is located anterior to the pubic symphysis, is a rounded mound of skin and subcutaneous connective tissue. It becomes covered with hair during puberty and provides cushioning and protection to the underlying structures. If we move a little bit inferior and posterior, we'll see the vaginal orifice, which is located between the urethral orifice of the urinary system and the anus of the digestive system. It is the entry point to the vagina, a muscular canal that accepts an erect penis so sperm cells can be delivered to the female reproductive tract. It connects the external genitalia to the cervix of the uterus. There are two sets of skin folds surrounding the vaginal orifice, the labia minora and the labia majora. We'll start with the labia majora, which are two elongated folds of skin that extend downward from the mons pubis on either side. They are often covered with pubic hair and contain fatty tissue as well as sweat and sebaceous glands. The labia majora enclose and protect the other structures of the vulva. Medial to the labia majora, on both sides, are the labia minora, two smaller and more delicate folds of skin. The labia minora are hairless compared to the labia majora. They're also highly vascular, and they can vary in size, shape, and color depending on the individual. They contain sebaceous glands, nerve endings, and melanocytes. The space between the left and right labia minora is called the vestibule. Each side of the vaginal orifice has a vestibular bulb. These bulbs engorge with blood during sexual stimulation. They also have small glands called the greater vestibular glands. Sometimes you'll hear people call them Bartholin's glands. They secrete most of the lubrication required for sexual intercourse. The clitoris is a small, highly sensitive erectile organ located at the anterior junction of the labia minora. It is composed of erectile tissue and contains thousands of nerve endings. The clitoris is homologous to the penis. It has bilateral corpora cavernosa that engorge with blood, just like the penis, and it plays a crucial role in sexual pleasure. Like the penis, it also has a glans, crura that attach it to the pubic arch, and a prepuce that covers it and protects it. The area of skin and muscle between the vaginal opening and the anus is called the perineum. It provides support to the pelvic organs and is also an important area involved in childbirth. Okay, we're going to move superiorly, and we're going to spend some time on female breasts because these are part of the reproductive system because they're required by mammals like us to nourish newborns. We also call the female breast the mammary glands. It is a specialized structure that functions in milk production, which we also call lactation. This way, a new mother can provide nourishment to newborns because in our species, newborns can't live on their own. They need to be supported for quite a while. The female breast is primarily composed of glandular tissue, adipose tissue, and connective tissue. Anteriorly on the outside of the breast, you'll see the nipple, which is a raised pigmented projection located at the center, containing numerous tiny openings called lactiferous ducts. These lactiferous ducts are responsible for milk release during lactation. The nipple is surrounded by a darker pigmented area called the areola, which contains specialized sebaceous glands known as areolar glands. These sebaceous glands secrete oils that lubricate the nipple and protect it during breastfeeding. The functional units of the breast are arranged in a lobular pattern, with each breast containing multiple lobes, and each lobe consisting of smaller lobules. The lobules contain clusters of milk-producing cells called secretory cells, or alveoli. These alveoli are connected by tiny ducts that converge into larger lactiferous ducts. The lactiferous ducts each end with a dilation called the lactiferous sinus that stores milk before it is released from the nipple. Within the breast, there are supportive structures called suspensory ligaments. These fibrous bands extend from the skin to the deeper layers of the breast and provide structural support. Suspensory ligaments help maintain the shape and firmness of the breast tissue. The breast also has an extensive lymphatic system that plays a crucial role in draining fluid and immune cells. Lymphatic vessels within the breast drain into the axillary lymph nodes located in the armpit region. The release of milk from the lactiferous sinus is called lactation. A woman who has recently given birth will produce milk, which is stimulated by the hormone prolactin from the anterior pituitary gland. Milk release, or lactation, is stimulated by the hormone oxytocin. Remember, oxytocin is produced by the hypothalamus, but released by the posterior pituitary gland. So we have two different systems happening here. We have prolactin stimulating the production of milk, and oxytocin stimulating the release of milk. Two different things going on. Sometimes you'll hear the release of milk called the letdown reflex. Okay, so now that you have the external anatomy of the female reproductive system down, it's time to talk about the internal anatomy. Unlike the biological males, the majority of the reproductive anatomy of biological females is internal. We'll begin with the vagina. The vaginal canal is capable of stretching to receive the penis and semen and provide a route for newborns to pass while being born. It is also how sexual fluid exits the body. The lining of the vaginal walls is wrinkled with vaginal rugae, or friction ridges. The vagina tilts posteriorly as it extends superiorly into the pelvic cavity to meet the inferior aspect of the uterus, which we call the cervix. The cervix sits in the superior vaginal canal, with the superiormost aspects of the vagina wrapping around the outer wall of the cervix. This creates a kind of dead-end area called the vaginal fornix. The entrance to the cervical canal from the vaginal side is called the external os. The entrance to the cervical canal from the uterine side is called the internal os. The uterus, also known as the womb, is a hollow, pear-shaped organ where an implanted embryo can develop into a fetus. Now remember, the cervix is part of the uterus. People don't typically know that all the time. It's really the inferior bottlenecking of the uterus. The main part of the uterus, superiorly, is called the body, and the region that extends even superior to that, above the uterine tubes, is the fundus. There's actually not much of a lumen or cavity in a non-pregnant uterus because it exists in a virtually collapsed state. However, as a fetus grows, the uterine lumen or cavity expands to accommodate the fetal size. The uterine tubes, which are also known as oviducts, and which you've probably learned them as fallopian tubes, but that's a name we're moving away from because it's an eponym named after a person, are two slender tubes that extend from either side of the uterus. They have finger-like projections called fimbriae near the ovaries to help capture and guide the released egg cell into the uterine tube. Just inside the fimbriae is a dilated area called the infundibulum, which is funnel-shaped and narrows into a space called the ampulla. The ampulla even further narrows on its way to the uterus in a section called the isthmus. The uterine tubes are wrapped in a layer of connective tissue called the mesosalpinx. Fertilization typically occurs in the ampulla of the uterine tube because the egg cell is only viable for about 24 hours, and that's about how long it takes to reach the ampulla. The gonads of the female reproductive system are the ovaries. They are a pair of small, almond-shaped organs located on either side of the uterus. They're responsible for producing and releasing egg cells during the sexual cycle, and they also produce hormones such as estrogen, progesterone, and inhibin, which regulate the sexual cycle and contribute to the secondary sexual characteristics. The female reproductive organs are supported by various folds of peritoneum referred to as ligaments. So I'm going to run off these ligaments for you, what they're called and what they attach to. We have the round ligaments, which extend from the uterus to the labia majora. the cardinal ligaments, which attach the cervix and superior vagina to the pelvic wall, the uterosacral ligament attaching the posterior uterus to the anterior sacrum, the ovarian ligaments attaching the ovaries to the uterus, the suspensory ligaments attaching the ovaries to the pelvic wall, and the broad ligaments attaching the uterus, uterine tubes, and ovaries to the pelvic wall. The broad ligament is more specifically the mesosalpinx and the mesometrium. Let's talk about the blood supply to these organs. There are 3 main arteries supplying the reproductive organs of the female on each side. From the abdominal aorta, an ovarian artery, a left and a right, goes to each respective ovary and uterine tube. From each internal iliac artery, there is a uterine artery. The vaginal artery immediately branches from the uterine artery and supplies the vagina. The uterine artery makes it to the uterus, travels upward, giving off branches into the uterine wall, leading to the arcuate artery, which travels along the uterine wall and over the fundus to meet its contralateral counterpart from the other side. It's called arcuate because it forms an arch. Spiral arteries branch from the arcuate artery, going right into the uterine wall and supplying it, while the rest of the uterine artery anastomose with the ovarian artery to supply the uterine tube. Another becomes the ovarian branch of the uterine artery to supply the ovary. Okay, so that's the gross anatomy. And as important, if not more, is the histology. Histologically, each organ in the female reproductive system exhibits distinct features that contribute to its specific functions. So we're going to talk about histology for a little bit so we can better understand the overall functions of each organ. And we're going to start with the gamete-producing ovaries, which are divided into an outer cortex and an inner medulla. Not only do ovaries produce egg cells, or oocytes, or ova, they also secrete hormones like estrogen and progesterone. The primary form of estrogen during non-pregnant reproductive years is called estradiol. The outer cortex contains ovarian follicles at various stages of development. In order of developmental stage, they are primordial follicles, primary, secondary, tertiary, and mature follicles. Each of these follicles consists of an oocyte surrounded by specialized cells called granulosa cells, which are the ones that secrete estrogen. The oocytes within the follicles also undergo maturation and development. As they mature, we begin to see other cells and structures in the follicle. In the next episode, we're going to talk about oogenesis, and we'll look more closely at these follicles when we do that. The inner medulla also contains blood vessels, lymphatic vessels, nerves, and connective tissue. The histological features of the uterine tubes include a mucosal layer lined with ciliated, simple columnar epithelium. The cilia beat in coordinated movements to help propel a fertilized oocyte toward the uterus. The mucosa also contains secretory cells that provide nourishment for the oocyte and the sperm. The muscularis is a muscular layer consisting of smooth muscle that facilitates peristaltic contractions to move the oocyte along the tube. And the outermost layer of the uterine tube is the serosa, which is a thin layer of connective tissue.
You buy a pair of socks, that's 2 socks. You buy a pair of Bombas socks, that's 4 socks. Because one purchased is one donated. Socks are the #1 most requested clothing item in homeless shelters. So when you buy a pair of super comfortable Bombas socks, you're also donating a pair. Bombas customers have powered over 150 million donations. So Bombas would like to thank you 150 million times. But we only have like 30 seconds. Go to bombas.com and use code AUDIO for 20% off your first purchase. That's BOMBAS.com and use code AUDIO at checkout.
Okay, let's talk about the uterus, which consists of 3 layers: the innermost endometrium, the outermost perimetrium, and the muscular myometrium between the two. The endometrium undergoes cyclic changes during the 28-day menstrual cycle. It is divided into 2 layers, the stratum functionalis and the stratum basale. The stratum functionalis is the functional layer and thickens in preparation for implantation of a fertilized oocyte. If fertilization does not occur, this layer is shed during menstruation. The stratum basale remains intact and gives rise to a new functional layer in the next cycle. The myometrium consists of smooth muscle that contracts during labor and childbirth. The myometrium also undergoes changes during the menstrual cycle under the influence of female sex hormones. We'll talk more about childbirth in a subsequent episode, but that myometrium muscle contraction is what causes menstrual cramps and a lot of the pain during childbirth. The perimetrium is the serosa covering the uterus. Now remember we talked about the cervix, which is the inferior portion of the uterus that connects it to the vagina. The cervical canal is lined with stratified squamous epithelium with a layer of columnar epithelium deep to that. The deeper layer contains cervical glands with goblet cells that produce mucus, which helps in sperm transport. The squamous cells are subject to a lot of turnover, meaning they're susceptible to mutations. Mutagens, like chemicals found in cigarette smoke and the human papillomavirus, HPV for short, can trigger these mutations, resulting in dysplasia. Dysplasia means an abnormal growth or development of a tissue, and that can ultimately lead to cancerous tumors. If it's caught early, cervical cancer is very treatable, which is why it is recommended to have regular cancer screenings by your gynecologist. These cancer screenings consist of HPV tests to check for human papillomavirus and what's called a pap smear test. The pap test is where a sample of cells are taken from the cervical lumen and examined under a microscope by a pathologist to see if there is any changes in the cells, specifically precancerous cells or cancerous cells showing up as cervical dysplasia. When it comes to cervical cancer screening, there are recommendations from the American College of Obstetricians and Gynecologists, and this is what they recommend. Women ages 21 to 29 should have a pap test alone every 3 years. HPV testing alone can be considered for women who are 25 to 29, but the pap tests are preferred. Women aged 30 to 65 have 3 options for testing. They can have both a pap test and an HPV test every 5 years. They can have a pap test alone every 3 years, or they can have HPV testing alone every 5 years. After age 65, you can stop having cervical cancer screenings if you have never had abnormal cervical cells or cervical cancer, and you've had 2 or 3 negative screening tests in a row, depending on the type of test. However, if you have a history of cervical cancer, are HIV positive, have a weakened immune system, or were exposed before birth to a hormone given to pregnant women in the 40s, 50s, 60s, then you may need more frequent screenings. The vaginal mucosa lining the vaginal canal includes non-keratinized stratified squamous epithelium. This type of epithelium provides protection against friction during sexual intercourse and childbirth. Deep to that is the lamina propria. That's the underlying connective tissue layer of the vaginal mucosa and contains elastic fibers, blood vessels, and nerves. As we know, structure tends to dictate function, and that is never truer than when we're talking about histology. All right, so that's the anatomy, gross and histological. So now we'll get into the physiology of what goes on with the anatomy. I'm talking about puberty. I explained what puberty is in episode 69, so if you're not sure, go back and listen to that because I'm just going to get on with where it pertains to biological females in this episode. Assuming a biological girl is not malnourished and lives at a healthy weight, puberty begins around 8 to 10 years old in affluent countries, but significantly later in many developing countries. Now, here's something interesting. A 1997 study of more than 17,000 girls in the United States found that 3% of African American girls and 1% of Caucasian girls started puberty at 3 years old. Now, that doesn't seem like a very big difference, right? 3% to 1%. But when they looked at 7-year-old girls, 7% of white girls had started puberty, and a whopping 27% of black girls. Why this is happening isn't entirely understood, and all we have right now are hypotheses from researchers, but some think genetics plays a role, and others look to socioeconomic status and the stress that comes with living in disadvantaged situations. But again, a full understanding isn't really available, but the trend is well documented. In girls, puberty is triggered by the same hormones we talked about for boys. However, there is one important difference: body fat. The caloric demands of pregnancy and lactation are dependent upon an adequate supply of body fat. Your body knows this, and without it, it will not risk a pregnancy. That means no ova will be released unless the body can handle its fertilization, at least when it comes to available body fat. The release of an ovum from an ovary is called ovulation. About 17% fat is required for the start of ovulation and menstruation. You've probably heard that biological females need more body fat than biological males. This is true. If an adult woman's body fat falls below 22%, she may stop ovulating and menstruating, making her unable to conceive. For this system to work, the brain needs to be aware of how much body fat you have. Remember leptin from the nutrition episodes? Leptin is the hormone secreted by adipocytes, or fat cells, and it tells the brain how much fat you have. If the leptin level is too low, the hypothalamus does not secrete gonadotropin-releasing hormone. This is why I mentioned malnourishment earlier. Puberty is delayed in malnourished girls and excessively thin girls. Sometimes we see girls who have very low body fat because they participate in activities that require vigorous, frequent physical activity. Not to mention, the activity favors someone who's light. Gymnastics, for example. Ovulation and menstruation may cease even in adult women who become underweight. A 2022 study published in the International Journal of Environmental Research and Public Health found that the prevalence of menstrual disorders among female athletes ranged to be up to 61%. The higher prevalence was found in sports like gymnastics and endurance sports like distance running. However, team sports like volleyball and soccer also presented a considerable percentage of menstrual disorders compared to the general population. This reinforces the importance of coaches and physicians to monitor the menstrual regularity of the athletes because disruptions in the menstrual cycle can lead to long-term negative effects. Now, if there is enough body fat, the gonadotropin-releasing hormone level rises in late childhood and stimulates the anterior pituitary to secrete follicle-stimulating hormone, FSH, and luteinizing hormone, LH. FSH stimulates the development of the ovarian follicles that harbor the oocytes. Those follicles also secrete estrogens, progesterone, inhibin, and a small amount of androgens. From ages 8 to 12, there is a gradual increase in these hormones, but in the teenage years, the rate of secretion increases. The estrogens include estradiol, the most abundant, estriol, and estrone. Most of the changes we see in girls during puberty are the result of estradiol and androgens. These are what we consider to be feminizing effects like the onset of breast development, which is called thelarchy, and that is the earliest sign of puberty. Estrogen and progesterone from the ovaries and prolactin from the anterior pituitary initially stimulate lobule and duct formation in the breast tissue. After thelarchy, we see pubarchy, the appearance of pubic and armpit hair. We also see sebaceous glands increasing and axillary glands increasing. Pubarchy is stimulated by androgens from the ovaries and the adrenal cortex. These hormones also stimulate the onset of libido, or sex drive. As you might have predicted, biological males secrete 12 to 16 times the volume of androgens per day compared to biological females. The first menstrual cycle is called menarche. In the Western Hemisphere, we see menarche occur at about 12 and a half years old on average. Just because a girl has her first menstruation, though, doesn't mean she can produce offspring. There's usually no ovulation for about a year or so after menstruation begins because the maturation of an ovarian follicle takes the better part of a year. So those menstrual periods are referred to as anovulatory, meaning no ovulation. No ovulation, no ovum. There's more to puberty where estradiol is concerned. It stimulates the transformation of columnar epithelium into squamous epithelium in the vaginal wall. It stimulates the growth of the ovaries and the secondary sex organs. And it stimulates the anterior pituitary to secrete human growth hormone, resulting in an increase in height and widening of the pelvis. Estradiol also stimulates the deposition of fat in the breasts, mons pubis, labia majora, gluteal region, hips, and thighs. It makes a female's skin thicken, but not as much as we see in males. So a female's skin is thinner, softer, and warmer. Essentially, estradiol is responsible for the bodily appearance we tend to associate with women. The hormone progesterone mainly targets the uterus, whose inner lining must thicken and vascularize to support a developing embryo. If an ovum is fertilized, it typically happens in the uterine tube, and the conceptus spends the first few days traveling to the uterine cavity. If it's to continue to develop, it has to implant in the uterine wall. After ovulation, which occurs about 14 days after the onset of a menstrual period, a rising progesterone level prepares the internal lining of the uterine wall for this potential pregnancy. Estrogens and progesterone, both steroid hormones, use negative feedback to regulate FSH and LH secretion. And like we saw in males, inhibin only regulates FSH secretion. So you can see why there would be so many hormonal similarities in males and females, beginning with puberty. The hormones are the same, but the volume we see in males and females differs. In males, the androgen levels are high and the estrogen levels are low. In females, estrogen is high and androgens are low. In females, the secretion of these hormones rises and falls over the course of about 28 days. This cycle of hormonal secretion is divided into the ovarian cycle, which regulates the development and release of an ovum from an ovary, and the menstrual cycle, which regulates the preparation of the uterus for implantation and pregnancy. We won't have time to talk about these cycles in this episode, but they will be the focus of episode 71. Earlier, I talked about male climacteric and a little bit about menopause. So let's get more specific about female climacteric and menopause. As I mentioned before, climacteric is the decline in reproductive hormone levels, and menopause is the cessation of menstruation and typically takes place between 45 and 55 years old. So I guess the big question is, if men can continue to father children throughout their lives, why do women go through menopause? There is more than one school of thought on this. It could be that having and raising children is hard and takes a toll on the human body. So it is better to be infertile after a certain age to reduce the risk that pregnancy and childbirth pose on a woman after a certain age. It could be that humans take care of their young for a relatively long time compared to other species, and it's important to be healthy enough to do that. So from an evolutionary perspective, menopause seems to present an advantage. But if we look at the fossil evidence from our hominid ancestors, we see that their life expectancy was less than 40. So they may actually have been fertile their entire lives. And the menopause human women experience today is simply because we live so much longer than our ancestors did. Either way, let's discuss what happens with females during climacteric and menopause. On average, females are born with about 2 million eggs in their ovaries, each with its own follicle. That's all the eggs she'll ever have. Unlike males with sperm, females do not continue to synthesize more eggs after birth. Many follicles mature, but only a tiny fraction actually release their ova. These unused follicles degenerate, never to be heard from again. When the number of remaining follicles is down to about 1,000, climacteric begins. At this point, the remaining follicles' hormone receptors are not as responsive to FSH and LH, which means they will not be stimulated to secrete as much estrogen and progesterone as before. The decline in these ovarian hormones results in atrophy of the uterus, vagina, and breasts. The lubricating secretions of the vagina decrease during sexual arousal, and the vaginal wall thins and loses some of its elasticity. These changes can make sexual intercourse uncomfortable and increase the incidence of vaginal infections. There are also more universal changes as a result of the declining steroid hormones. For example, a thinning of the skin, a decline in bone density, and a rise in blood cholesterol levels. This is why we see an increased risk of cardiovascular disease and osteoporosis. One of the most recognizable signs of menopause is hot flashes. A hot flash is the sensation of a flood of heat running up the trunk of the body and into the head and neck area, often accompanied by sweating and headaches. The changes in hormone balance cause blood vessels to constrict and dilate. When there is a sudden dilation of the blood vessels near the skin surface, the resultant sensation is heat at the periphery and then sweat. The headaches are from dilation of the blood vessels in the head. The fluctuation of estrogen and progesterone levels may also cause mood changes, insomnia, and night sweats. You've probably heard of hormone replacement therapy, or HRT, as a method of treating the symptoms of menopause. HRT is a prescription of low doses of estrogen and/or progesterone to relieve some of these symptoms. There's a lot of debate about hormone replacement therapy, however, as it definitely has pros and cons. Obviously, the symptoms of menopause can be extremely uncomfortable, and relief from those symptoms are the main benefit of HRT. But it does not come without risks. According to the Mayo Clinic, hormone replacement therapy for menopause can increase a patient's risk of heart disease, stroke, blood clots, breast cancer, gallbladder disease, and endometrial cancer of the uterus. There are a lot of variations to the types of hormone therapy and the way hormones are delivered, and the risks are different depending on a patient's age, how long it's been since menopause began, and the kind of hormone treatment they're receiving. So if you're considering hormone therapy for menopause, you should have a comprehensive conversation about it with your gynecologist. I am not a gynecologist, so please keep in mind that this podcast is for information purposes only.
You buy a pair of socks, that's 2 socks. You buy a pair of Bombas socks, that's 4 socks. Because one purchased is one donated. Socks are the #1 most requested clothing item in homeless shelters. So when you buy a pair of super comfortable Bombas socks, you're also donating a pair. Bombas customers have powered over 150 million donations. So Bombas would like to thank you 150 million times. But we only have like 30 seconds. Go to bombas.com and use code AUDIO for 20% off your first purchase. That's BOMBAS.com and use code AUDIO at checkout.
Okay, so that's a lot for one episode. I think we're going to cut it off there. In the next episode, we'll talk about the menstrual cycle and the ovarian cycle. We'll get into oogenesis, folliculogenesis, and all that stuff. We'll continue on and finish the female reproductive system in that episode. Once again, thank you to Jenna from San Antonio, Texas, for sending me that question about male climacteric. I appreciate you reaching out. And thank you all for listening. I really hope that this podcast is helping you get your B or better in A&P, or simply helping you understand more about how the human body works. Once again, if you're liking this podcast, please rate and review it. Leave me a comment on Spotify if that's how you're listening. It really helps get the podcast in front of other people who might benefit from it, and I would love it if as many people are listening as possible. So thank you once again for doing that, and I will talk to you next time. Anatomy and Physiology Bit by Bit is a production of Minus 55 Media and is hosted by the Believe Network. Please take the time to rate my show and leave a review. You can also check out the content I post on Instagram and YouTube as @StudentHelp4AP. That's the number 4 AP. Special thanks to my family, Bucks County Community College, and McGraw-Hill Education, where your instructor can find Anatomy and Physiology Digital Suite, my low-cost tutor video-based digital learning solution for anatomy and physiology currently being used at several colleges and universities. If your instructor isn't using Digital Suite, let them know about it. The link is in the show notes.